hose worth of knowledge in heat-related illness because it was hot and humid in the half Iron marathon, or the half Ironman rather, and then it rained and cooled everything down. And once that moved out, all the humidity kicked up again, and people were literally just falling at the finish line. And we got on real quickly.
There's no humidity down here, so.
Yeah, that's right. That's right.
Humidifiers, maybe. Natural humidifier.
That's why our skin looks great.
Yeah.
All right, here we go, guys. You ready? Are you going 3, 2, 1? What's up, y'all? Welcome to the Sports Medicine Broadcast number 216, Marathon Medicine, with Drs. Castle and Cianca, and of course my beautiful co-host, Dr. Josh Yellen, repping the University of Houston Masters of Athletic Training. Dr. Cianca sent me his resume yesterday, and I was just kind of, I don't know, stunned, I guess. 12 years after graduating undergrad is when you finally finished up with fellowships and residencies and all that kind of stuff. 12 years. This will be my 12th year after undergrad practicing as a professional. I can't imagine just now finishing school and then next year starting, I guess, my own professional deal.
That would be the 26th grade.
26th grade. Well, all right. And we also have Ray Castle. He's an associate professor and athletic trainer at LSU. He's been in the profession 25 years. And Dr. Cianca is a medical director for the Houston Marathon Committee. And he's been in the profession as a doctor for 20 years. So this episode will be sportsmedicinebroadcast.com/marathon. Again, sportsmedicinebroadcast.com/marathon. Without much further ado, Dr. Castle, I know that right now you're recovering from an Achilles injury and you're going to try and make it down, but why don't we start off with your athletic trainer story, and then we'll go from there.
Yes, great to be here. I've heard a lot about the show in the past and have had the opportunity to see some of the episodes also. So I just want to first commend what you're doing, Jeremy, and your students in the broadcast area as well. I've been an athletic trainer for about 25 years now. I actually did my undergraduate work here at LSU and left there, went to University of Southern Mississippi as a graduate assistant, and I've had a couple of spots here and there in Memorial Sports Medicine in Lake Charles and UL Lafayette, and then I've been back here in I've been a little stint in Florida, and then I've been here at LSU since 2002. So that's where I've been doing a number of different coverage and a number of different events with travel with the Olympic Committee, et cetera, periodically. And then I've been doing really some of the race medicine since about 2012. Really got interested in that area. So covering triathlons and obviously different marathons. And currently right now I've been in my finished my third year as the medical coordinator for the Louisiana Marathon, which runs the same weekend as the Houston Marathon. So that's that's kind of the nuts and bolts of it.
All right, Dr. Cianca, how did you get involved with marathon medicine?
Well, I came down to Houston in 1992 to do a fellowship in sports medicine at Baylor College of Medicine. And after that, I began my practice, which I'd always been interested in running. I'd been a competitor when I was younger. So I started, not sort of a novice running practice, and got the attention of some of the people that were in charge of the Houston Marathon at that point. And my predecessor stepped down and recommended me to them. So I thought, well, this is an opportunity that's too big and too good to pass up. So I took it, and that was in 1998. My colleagues at the time, Dr. Chorley and Dr. Devine, helped me out quite a bit. Dr. Chorley is still in town and works with me, and now Dr. Devine is a medical director of the Flying Pig Marathon in Cincinnati. So I've been doing this now quite a while, and this coming up this year will be my 20th year with the Houston Marathon.
And Dr. Cianca, you have an interesting background in terms of your training. You are a physiatrist by training, is that right?
That's right.
And can you talk a little bit about how that physiatry training has helped you in, pursuing some greater advances in marathon medicine?
Well, the whole focus of physiatry is a bit different than a lot of other medical specialties, particularly orthopedics, which focuses a lot on structural problems. And physiatry, across the board, we take care of a lot of different types of problems, really focuses on function. What are you going to do with this problem that you have? How are you going to make it workable for your current situation or for what you hope to do? So with that in mind, looking at, in this case, a mass participation event, you really have to think about the moving parts of that. And then with regard to the actual clinical aspects of marathon medicine, I think more about the training and the recovery from training, not just the particular anatomic structure that might be involved, because usually there's more than one structure involved, and it's really on a more functional basis, not necessarily a purely structural one. So the thinking is really what's influenced me a lot, the ability to think broadly and in a functional way has really made a big difference for me with this.
Is it safe to say that the thought process and training of physiatry and the thought process and training of athletic training go hand in hand in this particular case?
I think so. I've always enjoyed working with athletic trainers. Back when I was up at the University of Rochester working games there. And I find that trainers are ideally suited to what I need to do at a marathon because they're skilled in a lot of areas. They're very versatile and adaptable. You know, if I need something, I can ask a trainer to do it, and chances are they're going to know how to do it. And that might not be the case with a lot of other more specialized healthcare providers. And of course, some of my colleague directors are athletic trainers. And so any of you out there who want to help with Houston Marathon, there's an open invitation to join us every January.
Great. Jeremy, I'm sorry. I think I interrupted a question that you had.
No, go ahead. Go ahead.
So if we can, you know, we got both of your backgrounds and kind of how you got into this. Start with you, Ray, and let's start a little bit about how you started to move into marathon medicine and some of your experiences, especially from the Boston Marathon.
Well, this actually started. So Dr. Cianca, we have a mutual connection, Chris Trianos, who he is the medical coordinator for the Boston Marathon. So actually, how I got moved into that indirectly was actually started around 1999. Chris and I were roommates at the Olympic Training Center in a medical rotation, and he, kind of the north and south, and we've been good friends, very good friends since then. And he'd always asked me to come up as well, and then also as I'd always thought about going up there, and I heard it's a great experience. And then with also know Mark Larson, who's at Boston University, and they've been doing some things bringing athletic training students up. So that's decided to do that and bring several students up. And that's when in 2013 was the first year we did that. I had 3 students come up, and it is just an incredible experience. And I've used Chris and look at the other, the major 5 races and the work that obviously that Chris and Dr. Cianca and other medical directors, coordinators with the International Institute for Race Medicine. Definitely have to give a plug to that group and the effort they're doing in trying to standardize healthcare across marathon and providing good resources. So that's where I've just done that. I've gone different races and then applying what I've learned in other coverage and listening and doing a lot of different events like the Houston Ironman. I've done that race, done some other races, and just blossomed into, I just really enjoy being in that running environment, providing medical care. Everyone's got a different passion, or they got a story behind that. And, it's fun helping to see them succeed and help them, in some way cross the finish line. And if by chance that we can't, then we're there to help provide appropriate medical care for them.
And as we keep moving down that trend, Ray, let's talk with you a little bit about, from an athletic training perspective, tell me some of the advances that you've seen in emergency action plans and some of the preventative things that are happening in marathon medicine.
Well, I think the first thing that, we see this, and it was, obviously with what happened at Boston in 2013, it brought to light a very, kind of we know this already, that any incidents can occur at any given time, and having really the importance of having a planned response. It's not impossible to plan for everything, but from an emergency standpoint, I think you're seeing a lot now, and having, it goes back to a lot of what assets you have there available. And, our race, our marathon, here in Baton Rouge is about 8,000 runners over the 2 days, about 6,000 or 7,000, about 6,000 on the half and the full. And that runs differently, whether it's it's a point-to-point course, or you have a loop course like we have here. And really just assigning, I think, what Dr. Cianca mentioned as well, looking at with the skill sets, you have to look at what do you have in general, what you have as your assets, from nurses to physicians to PAs to athletic trainers, to the EMS, et cetera. And it's really a job, I feel, is trying to, you have the medical plan is pretty consistent, and you have to communicate. It involves a tremendous amount of communication with public safety officials, and trying to see where plug and play to make sure you have consistent care throughout in a response. So that's the emergency side, but then also making sure you're accessible for any type of injury you have. And then you look at more of a standard of care. You're looking at heat-related illnesses, hypothermia. Those are obviously the more cardiac arrest. Those are some of the bigger things you have to be aware of, and being able to handle those. So the heat-related illness, being able to do immersion tanks, colorectal temps, and you have to, not just that, but making sure other situations like hyponatremia and how you treat that person. It's you're doing a very rapid response. So I think that's probably the biggest thing that gets into, is putting people with appropriate training, and where they're going to succeed, put them in places where along that medical plan that you're able to have a good outcome as overall from a race logistics. And that's one thing that's really I appreciate from having worked a large scale event like the Boston Marathon, is you have a number, it's a great interprofessional collaboration, but their individuals are put in different areas to be successful, because that's what they're trained to do, and you mix and match appropriately along those lines.
John, I want to throw it over to you and talk a little bit about, from a physician standpoint, some of the things that you've learned over time in terms of heat-related injuries, emergency action planning, and how you're treating the various injuries that are coming across your table.
Well, as Ray was saying, there's a lot of commonality to what you're going to see one race to the next. I mean, the biggest predictor for me is the weather, always. If it's going to be warm, it's going to bring us a certain set of circumstances, and if it's cooler, it's going to bring us another. So warm weather is sort of my first measure of what we should be prepared for, and preparation is really the key to any mass participation coverage. You've got to plan for things that could happen. They might not happen, but you need to be prepared for them if they do, whether that's something within the race itself or something external, like what happened in Boston in 2013. You can't be on point for every single thing that could happen, but you can be prepared for the situations as best you can. And that gets to Ray's point about assets, getting yourself scaled up for what you're going to need. So when I look at, typical marathon kind of scenarios, if it's a hot day, I know I'm going to see people with hydration problems and hydration illness, which can range from too much to too little intake, the heat problems that go with it. And it doesn't necessarily only happen with a hot day. You can get people that get hot in a mild day even, or even frankly in a cold day. It depends on their exertion and their basically how hard they're driving their own furnace. So, we definitely have some protocols that we follow, but we try to stay nimble with regard to the day and what it's likely to bring, as well as the individual, because not everybody's going to fall right into that protocol all the time. You do have to be alert to anybody's individual presentation. Now, beyond that, when you talk about public safety, that's almost harder to prepare for, because anything can happen, as we've seen, and you really do have to have outside help in case something strange and unusual happens that you can't possibly be in control of. So cooperation and preparedness throughout a city and the city agencies that would oversee your event is really, really important.
John, you know, when we were going through the Houston Marathon training before the actual marathon, you and your team presented an interesting statistic about the weather. There was some sort of threshold that if the weather in the morning is below, I want to say 55 degrees, then the likelihood of a mass amount of heat-related illnesses is lower. Can you talk a little bit about that?
Yeah, absolutely. Weather, again, is a huge driver of what we're going to see. And if our start temps, the starting temperature at the start, which we use what's called the wet bulb globe temperature, which takes into account both the ambient temperature, the humidity, the radiant heat, all factored into an equation to produce a number, which is weighted towards humidity. If that number is under 50, we're in great shape. If it's under 60, we're going to be in pretty good shape. But if we start over 60, and certainly in the upper 60s, we're going to have a long day. We're going to see a lot of people. That's pretty much true anywhere. Cold weather, people do better in, believe it or not. They don't, if you're cold, you just run harder. And if you're hot, a lot of people don't make the right decisions, either first and foremost to slow down, and secondly, to be smart about what your fluid intake is. It's not always, oh, I'm hot, so I should drink more. That's not a one-to-one correlation. So again, the start temperature really dictates to me what I need to be prepared for that day. And without fail, I can show you statistics for 19 years that demonstrate that when temperature is at in a certain range, we're going to probably expect between 1% and 2% casualties. And if it's over a certain range, we're going to expect 3% to 6% casualties.
And so along those lines, a lot of people would say, and I remember another statistic you presented was, believe it or not, in the half marathon, it's possible that you start to see more heat-related issues because they're pushing themselves harder.
Oh, absolutely.
And that got into a discussion about, well, sometimes not always pushing electrolyte-based fluid is the best. And so can you discuss from a medical standpoint why you would push sodium versus potassium and the different problems and how you're determining those types of decisions?
Yeah, sure. There's a lot of, frankly, mythology about hydration, and more so at the competitor level. Participants, whether they're experienced or not, tend to follow what everybody else in their group is doing, right or wrong. Healthcare providers, in particular, trainers and sports care physicians, know better, but they don't always recognize the situation. So, as I said earlier, being hot doesn't equate to drinking more fluid. If you're too hot, drinking more fluid may help you sweat more, but it doesn't really, it's not a direct signal to be less hot. The only way to get less hot is to slow down. You got to turn the furnace down a bit. That is it. Now, if you're underhydrated, sure, you'll be less efficient about cooling, but you're already too hot because you were pushing too hard. So fluid is part of the situation that's used to treat heat, but really behavior drives most of that. And so people have to realize when they're hot, they need to slow down. Now, what to give them is a good question. Water, by and large, is sufficient for most mundane sort of hydrational needs. But when you're out there more than an hour and you're a heavy sweater and your sweat is particularly salty, which is not unusual, you do need to replace sodium, whether it's as a general dietary guideline or within that setting of the competition you're in. So that becomes very individualistic, and people really, meaning participants, really need to understand what their needs are. And that's the first step for me. Now, how you react to that as an on-site provider it's really only a reaction. You got to go with what you can see and get from the person that's in front of you. So I look at body weight. What was their weight hopefully before the race, and what is it now? What's their sweat like? Is it profuse? Is it grainy? and salty? Are they urinating? What color is their urine? So there's lots of signals that would give me a clue about what to give them. And so you have to evaluate all those before you decide. And I wouldn't say that one particular situation requires this all the time or that all the time.
Ray, I want to throw this back over to you. Some of the lessons that you've learned over your experiences through the different Ironmans and marathons, as far as prevention, discuss a little bit about the steps that you go through in terms of trying to prevent some of these medical issues.
Well, I think the first thing that I want to reiterate, what Dr. Cianca mentioned was the temperature. I mean, you have to be very tuned in, and we're watching weather. Obviously we start a week out, but really those weather conditions really don't start to tighten up and until about 3 to 4, about 3 days out, you should really start getting pretty consistent temperature. You look at historical data as well. I think that one is educating runners, and with any type of mass participation event, runners are going to they will somewhat habitual, or they're going off of what more of a trend is and what their groups are running, what they're from a hydration and fluid standpoint. One thing that you have to take in mind based on the type of race, so that our race here, I'm going to give us an example. The Louisiana Marathon, we have it at the exact same day as the weekends of Houston Marathon. Pretty consistent weather throughout. And probably the difference, though, is that people may not take into account is that we have a single start, which starts at 6:30, 7 o'clock in the morning, versus Dr. Cianca, y'all have, about 35,000 runners, right? And have several waves?
We do have waves. We have about 25,000 runners, yeah.
Yeah, so your last wave may not start, till about 8:30 or so, or 9 maybe?
Well, they're about 20-minute waves, yeah. So depending on the year and how we do our wave starts, they definitely could be 40 minutes after the starters, the elites. So yes, there's definitely a prolonged start time.
Yeah, so I guess to add with that, it's more of what you think about for prevention is, and it starts. I'm a firm believer that you can, you hear about, I'm gonna go do carbo loading the day before a race. So how a runner is going to perform. And really those ones that really push themselves, those hard runners that we see a lot of, more so than the slow runners, that they are, 3 and 4 weeks out, 2 and 3 weeks. This started, potentially, unless they have an illness, that they may have an illness that makes something, how they're going to perform is affected, how they may do something consistently when they run, how they eat. Think about anxiety could be an issue as well. If it's their first race, if they have a later start, and they're changing when they run, the environment, if they're from a different area of the country coming in. So a lot of it, I think, is just trying to provide good common sense information on, try to stay as normal as possible. Obviously it could have some intestinal distress during the race, or having diarrhea, and that adds for additional fluid loss, any number of different events. But then, once they come across and they present, you have to really be a very, we stress upon our physicians, and they look at it very aggressively, but it's on an individual basis. What were you doing? What have you done? Where are you? And it more becomes an independent decision of how you're going to provide appropriate fluid replacement in the medical care at that point in time.
Ray, in your experience, as far as nutrition, right? A lot of questions we get is, what should I eat? How should I eat it? When should I eat it? So in your experiences, when you're talking to runners, what types of foods should they be consuming, let's say a week, 2 weeks, 4 weeks before the race? And what type of foods should they be staying away from?
Probably, the obvious one we know of, and runners will do that as well. For the higher end runner and the intermediate, the beginner runner may not think about this, but I would say definitely stay away from high fat foods. There's always a risk of, you hear of a race, or heard a race about 2 months ago where a runner died, and they were ingesting a very good food that I like to eat, is in donuts. Eating a lot and running, you can have develop have a fat embolus. That's hypothetical. In theory, would happen, and but I think same way. Higher foods that are high, good quality foods, natural processed, sugars, eating those types of foods, trying to stay away from a lot of the processed foods and even, the different drinks and things like that. So I think the main thing is really looking at from trying to stay as consistent as you can, but a good runner is going to seek good advice on really what fuels them. Each engine runs a little bit differently. And I think that's something that, from a definitely higher carbohydrate, having good fluid source, a consistent fluid intake, and not hyperhydrating overboard. Obviously, that becomes, you've heard of individuals who have had situations where they've had too much fluid in their system, or just like conversely too little. So, eating fruits, vegetables, the main thing is having energy and having that fluid intake is a good balance. And the typical, like Dr. Cianca mentioned, the typical person mowing the yard or doing that demand is completely different than going out and running, an hour and a half, 2 hours. It's a different demand. So they have to approach that in a little bit different fashion.
Sure. John, I want to throw it back over to you and talk about, from a treatment standpoint, as Ray talked about, the different heat-related issues. If we start to bring up different problems that we could see, we may see heat syncope, exertional heat exhaustion, heat cramps, et cetera. Talk a little bit about how, from a physician standpoint, what's the algorithm of how we're deciding where they're at and how we're going to treat those?
Well, the first thing that you really get a sense of is, where is that person? Are they with you mentally? Are they walking? Are they able to converse with you? That tells you a lot right off the bat. So their mental status, before you even touch them, you can kind of get a sense of they're off someplace. They're really getting out of it, even if they're on their feet. So that's the first thing I look at. And if they're not there, in other words, they're a little obtunded mentally, then that immediately bumps them up to a serious situation. If they're walking and talking, but they're sweating a lot and they're complaining of being fatigued and hot, well, I'll sit them down, get them cooled down, make sure they can take fluid orally, and encourage them to drink as they feel they need to. Now, if they come around, there's really not much more to consider. And usually that's the case with heat syncope or, simple heat fatigue, if you will, and cramps, the same thing. But as soon as people start to get woozy and lightheaded, or they start to be a little vacant mentally, we're really thinking about a different situation there. And I think it becomes very important to know what other parameters are in play. Heart rate is helpful. Blood pressure is very helpful. Obviously, if you're dehydrated, your pulse is going to be elevated. Your blood pressure is going to be low. And that would be one indication that you're probably fluid low, and you'd have to encourage them to hydrate. Now, in more vigorous situations where you really need to give them fluid more aggressively, you cannot go to that step without knowing what their electrolyte level is, particularly sodium. So we do a minor blood draw and do electrolyte testing on site to find out what their sodium level is. If their sodium level is normal, we can be a little bit more liberal with fluid, in particular IV fluid. If their sodium level is low, then we're going to be very, very careful about what we give them intravenously. And that mistake has been made too many times, where people assume that somebody's dehydrated, start plugging in IVs and pumping fluids into them, and that could lead to disaster, frankly. So if you're going to take the step towards more aggressive hydration, which we don't do very often, by the way, then you need to make sure you understand that person's chemistry, their sodium level in particular. And as I said, the first steps are really just looking at how they are. If they're with you and conversant, the seriousness of that goes way down relative to somebody who's not.
And so let's stay on that topic a little bit and talk about, somebody doesn't understand that particular decision-making process and doesn't understand the person's chemistries, and they push sodium. Medically, what are some of the issues that could potentially come out of that?
Well, it's not pushing the sodium that's the problem. It's pushing the fluid, right? So in the setting where we're going to take a subset of people that get sick that come in with a low sodium level. That has happened largely because they've drunk too much fluid on the course. That's a behavioral problem. They feel that they need more than they really do. And that shows up by them presenting not really so sick as being not feeling quite right. They might have a headache. They often have gained weight, believe it or not. Their vital signs are pretty normal, if not a little bit towards the elevated side for blood pressure. And if you check their sodium, oftentimes it'll be in the low normal range, or obviously if they're sick, it'll be below what we call as our threshold for hyponatremia, which is about 130, where normal is usually 140 or 145. So how they present will tell me what I need to do. And I don't want to give anybody IV fluid unless they absolutely need it. So if they can't keep fluid down, they're vomiting or they're nauseated or they're just really, really dehydrated, I'm probably not going to give them IV fluid. Now, there are situations where they might be overhydrated and hyponatremic and unstable, and I'm going to give them hypertonic saline, which is 3% saline, which is had been very, very controversial for some reasons that were due to a lack of understanding of acute hyponatremia versus chronic. But in that setting,
for all those that are listening, John, can you discuss briefly the difference between acute and chronic?
Right. That's a good point. Chronic hyponatremia is basically present when somebody has had a low sodium level for weeks or months, and they tolerate it just fine for the most part, but at a certain level, it becomes problematic. You can't reverse that situation quickly because you have to allow the body to come back to a normal level gradually because it's accommodated to that lower level. In an acute setting where somebody's sodium has gone down in hours because of drinking too much fluid or what some people call water intoxication, it's a completely different setting. And in fact, you have to act quickly. Otherwise, the outcome could be very, very bad. So in that setting where it's an acute presentation and their symptoms are in alignment with that, then you can reverse their low sodium quickly and aggressively. And so that's where we get into things like hypertonic saline or certainly fluid restriction, because the whole balance of fluid to sodium is critical to the body's functioning, and you have to get that back on track as quickly as possible.
So the take-home message here is, despite the commercials that you're seeing about Gatorade and Powerade and all those other things, that may not be the best form of treatment. The best form of treatment is monitor your water intake, and let's see if we can keep some things down, PO or by mouth, and then let's move forward from there.
Well, that's a very good point to bring up, because there's really two issues there. One, what does the person do day in and day out? And I wanted to mention this earlier. If you're training for a marathon, that's not a 1 week endeavor. That takes months. And in that period of time, you have to learn what you need and what you need to adjust to. And hopefully, if the person's paying attention to that, they arrive at a good hydration plan. In crafting that, you may need sodium replacement. You may need electrolyte replacement. That's going to depend a lot on your own physiology, what you sweat, how much you sweat, and your performance level as well. If you're a high-end performer putting out heavy amounts of calories and a lot of fluids via sweat and breathing and urination, you're going to need more. And you're going to need to be more proactive about what you put back into your system, as opposed to somebody who's more casual and not working as hard. It's a completely different thing. But unfortunately, people hear the commercials, if you will, or the advice that just floats around in their circles and think that everybody's on the same playing field and needs the same thing. Well, that's completely untrue. So people have to be willing to take the time to evaluate their own situation for their capabilities. How are they training? What conditions are they training in? What's their performance goal? How has it been affected by their current actions and training regimen. So it's a very thoughtful process. And that's all from the participant's point of view. As a practitioner, obviously, I'm looking at the things I mentioned earlier. They're coming to me in a situation where they're not right anymore. Something's wrong. So I'm looking at more clinical factors to influence what I'm going to recommend for them at that point in time. But it really, those are two different issues. One is after the fact when I see them. And the other, which is frankly more important, is before the problem ever begins. How do you keep it away? How do you keep yourself well tuned, well prepared, and not too far to one extreme?
Sure. Ray, I want to kick it back over to you. In 2015, Doug Cosson and his team releases a new position statement about exertional heat illness, and about halfway through that position statement, he identifies a nice algorithm and talks about rectal temperature, etc. Talk about briefly your algorithms and some of the things that you're looking for when setting up some preventative measures for marathon medicine and endurance medicine.
Well, I think the first thing is, it goes back to what you have available, and as Dr. Cianca mentioned earlier, from our standpoint, we're teaching, we as an information standpoint, at the finish line or throughout the course. Obviously, if they're having a neurological, if they have an impairment, they're not with you, so to speak. They're not, or they cannot walk, they have that collapse, then obviously there's a problem right there. I think most part runners don't want to go into a wheelchair, but you may do it for a couple of seconds, let them gather themselves after they finish the race and move forward. It's those who cannot walk, they seem to be disoriented, or they have that appearance where they're just not quite with you, then we're going to bring them into the medical tent. And going on to answer your question, Josh, you're looking at it from a heat illness. Obviously, we're going to do an assessment with them in our main medical tent. The one thing we've not had, and for this year is to get, obviously having an iStat unit, which is a portable, point of care system. You can analyze various blood profiles, specifically looking at sodium is one thing. And so our protocols, we have those in place. So in case we do get one, we bring it in that day. We have a protocol versus if we don't, we're a little bit leery on, how we are going to approach from a hydration standpoint. If the person is suspected as having a heat-related illness, your primary, obviously above, a core temp above 104, your primary goal is you've got to stabilize that person from a heat standpoint. And you've got to be really cautious about where they're putting, going ahead and dropping an IV in, because now if they are hyponatremic, you're pushing fluids on them, you're just creating you've got to get the temperature stable. And ideally you want to do a quick blood draw, as Dr. Cianca mentioned, and that only takes a couple of minutes. You determine whether or not they are or they are not at risk for, being hyponatremic. And then at that point in time, you can apply IV fluids. And as they become responsive, hopefully they can intake fluids and other, higher sodium content items and fluids to replenish themselves during that process.
And Ray, when you're putting some of these emergency action plans together and protocols, are you referencing a lot of the position statements on the NHO website?
Yeah, we put that in place, and those are, and then also what it's. Some of there has to be some adaptability, but we have, a core rectal temp. So if someone is coming into our tent, we're going to, before that, we have to stabilize them before transporting, because once you put them into an ambulance, then there's no way to cool them down, having an effective cool down. So that requires us to work with our EMS, our physicians, our core medical team, race operations, and EMS, and how we're going to approach that. And again, making sure we want them to be stable before we even, or at least a stable point to move them, unless they're having some other type of emergent issue. If they're having a cardiac event, et cetera, then, that may be secondary to that, with being a heat-related illness. Then we're having to, you have to have protocols in place, but reiterate, they have to be nimble. They have to be flexible to the situation, to the environment, to the patient and what that's going, but being consistent in how you're going to provide that care.
Josh, if I can add something
go ahead.
to emphasize what Ray just said, and for anybody out there who's going to be taking care of field situations, and whether it's a short race or a long race, if somebody's hot, you have got to treat them on site. As Ray said, you can't put them in an ambulance and expect that they're going to do better. They won't. In fact, they're going to cook. And when somebody's temp is over 104, that's almost as critical as a heart attack in my mind. You've got to cool them down. And the more vigorously you cool them down, the quicker they're going to turn around and the less likely they're going to have a bad outcome. And Dr. Casa has shown that very elegantly in his field studies. So we fully endorse an aggressive plan to cool people. And the only way you're going to know the correct temperature is to do a rectal temp. Everything else is inaccurate. So you've got to get that initial data point. Just like we said earlier with other vital signs, if somebody's suspected of being hot and if somebody comes in that's cloudy mentally, one of the first things I think about is they're too hot. So a rectal temperature becomes one of the first steps I take. And if they're over 104, we start cooling them immediately.
Right.
And I think one to add to that, and as I think was mentioned earlier, was even in cold environments, you need to, if they're having a mental status issue, or they're presenting as that, you have to rule out whether they are hypothermic or hyperthermic. And people normally assume it's cold, they've been running, it's wet, they're hypothermic. When in actuality, you're doing just that you could confound the issue. So it's paramount to do that very rapid cooling, especially in marathons when you see, depending on the environment. I've been at races providing in a heat deck where it's not uncommon to have a 108.5, 109, and that rapid response there is the difference where they can actually they have no organ failure. They leave. They have a very good prognosis down the line. So minutes, seconds are very critical in that standpoint. And I know that I'm sure that you look at what the major 5 races do, and I observe that, and I ask a lot of questions along those lines because I think it's very important you see what consistently is done across. It doesn't matter if it's a small race or big race; they're parallel and based on what I use our protocols. I looked at the big races; it's no difference. It's just a numbers game and how you're going to approach it. Still the same protocols, and it's best practices.
Dr. Castle, did you say that you've seen a 108 or a 109 internal rectal temperature?
Yes.
Oh yeah,
yes.
All the time. All the time.
Here we're pretty good because they're very good temperate. The weather's been very excellent here at the Louisiana Marathon in mid-January, and I know it's the same over in Houston at the same time. So we've been very blessed with weather. But when you're looking at I've seen it some at Boston Marathon. We have a number of runners and you see that where you have 25 or 30 in a heat deck at one, 7 or 8 at one time, where anywhere from 106 to 108. It's pretty significant. So they have a that's what's really it's part of the fun part. And I'm gonna quote it's at races. Mark Larson. I was in the heat deck with him in 14, and also Dawn Emerson, the athletic trainer, and she's done a good bit of research also with heat-related illnesses, and they're in there, and Mark Listman says, hey, this is where it's happening. We're saving lives right now, no pun intended, because it is very, if someone comes in the medical tent, regardless of what it is, you have to assume, you have to rule that out, regardless of what they appear as. They've run a marathon. They potentially have maybe minor in appearance, but they may be having some very serious metabolic issues that need to be addressed.
All right, so I got a question real quick. Dr. Cianca, if somebody comes into the medical tent, does that mean that they cannot finish the race? Because, like at the Olympics, if they get any sort of assistance, then they're disqualified, something like that. So does that work the same for marathon?
Well, no, not strictly speaking. I mean, that is a stipulation for international competition and national competitions that you should not do anything to that runner until you're asked to do it. That means an elite level competitor. However, in general, in a participatory event, that's not true. Obviously, if they're in a situation where they need help, you can give assistance. Obviously, I would ask, but if they're down on the ground, and they're not in a position to ask, I would begin treatment. Now, if perchance they feel better immediately and they feel like they can run, and I feel like it's reasonable for them to do so, sure, I'll let them continue. And that's not going to be a penalty for them in that setting. But, in an elite level competition, that is a bit of an issue, and that is preached. Unfortunately, sometimes that gets stretched too far in terms of that does not pertain to everybody. It only pertains to these particular types of competitors.
Okay, fair enough.
In the Houston Marathon, Dr. Cianca, I was on the bike medic team this last time, and the one message that I remember really sticking was, when you see the professional runners, do not touch them until they say they need help. Because if you act and they don't need it, well, then they're disqualified.
That's true. Now, one caveat to that: if they're down on the ground and not breathing,
Well,
you better touch them quick.
That's right.
But, that's a completely different situation. But it's, in general, the whole premise begins on the notion of aiding a runner. So, and this could be true of non-medical aid, right? Somebody comes along and helps the person to their feet. I mean, we've seen this in the Olympics years ago, where the eventual winner was DQ'd because he got assistance crossing the finish line. So it has more to do than just medical aid. It's aid of any kind. But if you're in a situation where somebody goes down and it appears that they're in a catastrophic situation, all that stuff goes out the window and you do what you need to do. But in general, if it's somebody that's ambulatory, yeah, just ask first, or have them ask you.
John, I want to give some of our listeners an idea of everything that goes into a large scale event like the Houston Marathon. And so I want you to talk a little bit about when you start your emergency action planning and all the agencies and people that are involved to make sure that the marathon, goes off with as little incident as possible. So can you discuss a little bit about that?
Yeah, it's definitely changed and gotten more complex over the years. But I think in general, any race of any size should begin planning at least several months in advance. We start formally 6 to 7 months in advance. And at this point, my job is year round. I just finished working on our budget for 2017, which in and of itself is growing exponentially year to year. But the important point is preparedness, giving yourself time to get things in place and to get an idea of what you have, your assets, how you're going to deploy them, how you're going to interact with agencies. You can't do that the week before. You've got to start that months in advance. I think a safe time is like 6 months in advance, particularly for a larger scale race or one that covers a lot of ground. Get your agencies together, start having planning meetings. They don't have to be every week, but probably monthly, or at least every 6 weeks, you should be meeting to kind of go over scenarios and understanding what it is you're going to need to prepare for, and who's going to cover what, and what are your contingencies, and what's going to happen if this situation ensues. So that kind of planning broadly within the community is very important, but it's also probably the case that within your team, your medical team, that forward broad thinking is important too. I mean, we do all our layout planning, our provisions, what we're going to need, what we're going to need to purchase, so far, well in advance, months in advance. So even in a relatively smaller race, I think you would do yourself well to give yourself the time to know well in advance what it is you need.
And so as far as the agencies that the Houston Marathon is collaborating with, can you give, I was shocked by everybody that was involved. I mean, it's not just the Houston Fire Department or the Houston Police Department. So can you talk a little bit about how all the agencies are involved and how you're coordinating that communication from kind of the 30,000-foot view?
Well, a lot of it depends on the event profile, where it is, how many people are involved, the exposure that it gets, that the federal government kind of rates things on what's called a SEER level. So a SEER 1 versus a SEER 3, or they're different levels of risk. There's only a few events that are SEER 1 level, like the Super Bowl would be. But that could be the papal visit would be something like that too. So at that level, everybody's involved, and people are there that you don't even know are there. The FBI has a way of coming in and out without being seen, and other agencies of that sort as well. But, as a routine, of course, I deal with Houston Fire and Houston Police. They're integral to our race, just the management of the race. But then beyond that, too, if a situation were to arise that I would be ceding control to an outside agency, it might be one of those two agencies. It could be an arm of the federal government. It could be a bigger medical orientation, whether it's a regional response necessary, or if it's a police situation. So you get the layers of we'll say bureaucracy that are superimposed on your normal function depending on the situation. So yeah, we have all kinds of agencies at the table, including FBI, various departments of the HPD, as well as the usual HPD ground officers. HFD has different levels of interaction with us depending on the situation. And then we bring in regional assets that are on standby until we call them. So it's sort of a layered approach depending on the situation.
And can you I think it's called SETRAC, is that right?
Yeah, Southeast Texas Regional, I can't remember the RA and the C, but they're a regional organization. I think there's several around Texas. This is SETRAC is the Southeast region, and they are basically our regional response. They bring in all the assets that we would need if our situation got unusual, whether it would be we had to enact a course evacuation, or we had some sort of mass casualty event, whether it was within our race or alongside of our race or even external to our race. But those situations, we would bring in a bigger response, more assets from a broader region. And in that setting, I would then probably be giving over control to somebody above me, meaning outside the race, and assisting where I could. And essentially, that's what happened in Boston in 2013. And it kind of has to happen that way, but it's better if you have it in place, at least in your minds, how this is how it should flow. I mean, you can't predict what's going to be needed or where it's going to happen, but you should have at least in mind where do we get other people involved, other agencies and other entities such as SETRAC. And they're standing by. They assist during the day, but they got a large amount of assets on the periphery if we need them.
Right. If you don't mind. What's that?
I was just saying we have a similar thing here as well for our race. We have the State Fusion. It's a fusion center, which is similar to that, but it's under state police and Homeland Security. So we do this, very similar. We'll have a big meeting with state and local officials. They've done, obviously doing, the SEER level, doing threat assessments, et cetera. Number of different, probably 15 to 20 different agencies and sub-agencies within that. And, you've got to be, knowing what's going to happen. And at that point in time, they can mobilize at any time, and where you become, we become an ancillary resource, from medical care if needed to, versus, but they're taking control of the situation if needed.
Right. If you don't mind, and if you'd be willing to talk about it, John brought up the Boston Marathon, and you were there.
Yep.
You were there at the finish line.
Yep.
And so, can you talk a little bit? I mean, if it's okay with you.
Oh, it's perfectly fine. Perfectly fine.
Yeah. Can you talk a little bit about your experiences, what you did during the bombing, how your training as an athletic trainer helped you, and some of the things that you learned out of that?
Well, I think the first thing, where my situation was, where I was, we had a large, at the finish line and the finish chute, we had, I want to say maybe 8 to 10 physicians. I recall about 15 to 20 athletic trainers and about 30 athletic training students. And that's about a 100-yard area between the finish line and the main medical tent, which has about 230 beds. They're already set up to have level 1, 2, and 3 trauma areas, a separate heat deck, et cetera. So about another 200 various medical personnel, physicians, nurses, PAs, et cetera, there. So during that event, obviously, you don't realize I was ended up being about 40 yards from the bomb blast, and I was next to another colleague at the time, Larry Venus, and it was just instinctive. We recognized what it was. A couple of seconds later, the next bomb goes off, and we looked at each other and said, "Okay, it's time to go." So from there, I ended up running in. They had the snow fencing. I pulled the shears out, cut the fencing, and I walked right up in the middle of where the bomb blast had occurred. One of the things that I recognized afterwards, that I believe the number was about 190 victims that were transported, were moved from those sites and already out of that. The site was cleared in less than 20 minutes. Now, granted, that's an incredible number. And you look at the number of casualties, there were only 3 casualties, but and I don't say only, I shouldn't say only because that's not going to do it justice. But when you look at the use of improvised tourniquets, the immediate influx of care, you look at those numbers when you look at things that happen, say in military settings, looking with it. So the one thing I saw from the inside out was seeing how as emergency personnel, athletic trainers, physicians, EMS, it was moving so fast, but everybody just filled in, and it was like a swarm, and it was very calming in a very intense situation because everything ran very fluid when it looks like chaos, and everybody knew what to do. But it goes back to having a planned response. It goes back to, even as a planning side, letting the medical volunteers have an understanding of what to do, what not to do in any given situation. That's one of the things that they do in Cristianos. They do that, bring everybody together, and this is your area. You don't go beyond that area. This is your zone and what you do, and this is what you do. And if you see something suspicious, you act upon it and move from there. So I think but going back from a training standpoint, I think our training has been that we're always typically running forward already. We're already in the middle of intense trauma before EMS is typically there to practice or otherwise, and we're responding accordingly. So I think that, and having some of from a trauma background that helped in triage, that's probably the best thing that had, from my skill set as an athletic trainer. I think the one thing I've learned a lot more of, and you're seeing a lot, like what has transpired with the Hartford consensus statements that have come out, after the Sandy Hook that came out shortly after, then Boston several weeks later, they came out with a second one, and then earlier in the fall, they came out with a third statement, and really looking at the role of the first responder, pre-hospital medical care, tourniquet, hemostatic agents. You're seeing that as what's happened in the military setting is translating over to civilian care. So that's, in educating individuals on being responsive and empowering individuals, whether it be a layperson or to help out in critical situations, and being very prudent in those situations.
Josh, if I may, I would like to add a couple of points about that. I was actually at the finish line that year as well, and obviously I'm not a central provider for Boston, but I have a lot of contact with the people there, and I was in the tent when the blast happened and on the finish line afterwards. And that's not my usual treatment scenario. I work in an office treating outpatient musculoskeletal problems, so it's a very different situation than I'm used to. And it was life-changing, to be frank. But being part of that, you see what happens, what doesn't happen, maybe what would ideally happen. And that whole situation was it was incredibly slowed down, I think, as Ray was intimating. But it all transpired from the start to the time I left the medical tent to go to my hotel inside of 70 minutes. Everybody was gone. The only people left were the physicians. We were the last to leave. 70 minutes from start to finish. And in that time frame, some 200 people were evacuated to hospitals. We unfortunately did lose 3 people. But that was a tremendous amount of coordination. And it frankly did look like chaos. It was much like what somebody might see in a hospital in a code situation where you got a sea of people rushing to do something. And oftentimes there can be too many people. But in a situation such as it was in Boston, I mean, a lot of what had to be done was just clearing debris out of the way so you could find people. It was you can't really prepare for something like that. But the important point is that when something like that happens, you have to stop and do a quick assessment of where you are, what needs to be done, and act accordingly. Most people will tell you in the mass casualty response, the first reaction should not be to run to the scene. That, as Ray noted, when the second bomb went off, could put even more people at risk. So you do have to stop and think, albeit quickly, about what you're going to do next. And sometimes you do have to hold back, obviously, as a conundrum for a healthcare provider when you want to take care of people as quickly and as best you can. But sometimes you have to look at the whole situation and make sure that it's safe.
And John, with you being at the finish line during the Boston Marathon bombings, how did that impact how you started to coordinate for the Houston Marathon? What lessons did you learn out of that you applied to the Houston Marathon?
Well, that's a good question, because for years we had been planning for the what ifs, and that, we didn't envision that particular scenario, but we knew there were situations that could arise that would take us out of our usual practice. So it really had been several years that we were, addressing the issue. It ramped way up very quickly the day I got back from Boston. So April 14th, 15th, the wheels started to turn here as to what we were going to do differently. And frankly, it was mostly from the outside, because all of a sudden people started to realize where the vulnerabilities were. And, most cities have big events like we do here in Houston, or they do in Baton Rouge. So, everybody starts to take account of that, and it gets more interested. And of course, then, there's more planning that is done, which is a good thing. But, truth be told, we were kind of already there. We obviously are doing some things more intensely than we had been prior to Boston. But part of our planning over the years is to think about these situations that could happen, and largely because we have so many people there. And the hard thing about a marathon is that it's over such a big stretch of terrain, and even more so with an Ironman competition. You've got a lot of people in a big area. That's hard to really keep perfectly secure. So you better have contingencies in place.
Ray, I want to kick it back over to you. I noticed that you are the president of Action Medicine Consultants.
Yes.
And so can you talk a little bit about the services that your company provides, and your interaction and the types of things that Action Medicine Consultants do?
Well, we do a lot of, basically, it's in the nutshell, it's outreach sports medicine services through the area. So we focus a lot on triathlon races. We have Louisiana has become very big in the racing in that community. So we had doing the Louisiana Marathon. I provide my services as a medical coordination standpoint. A number of other races. We have one. The bigger one I did was a half Ironman here as a Riveroo triathlon back in November, and that's out in rural Louisiana, up in New Roads. I know where that is, Josh. And you have a rural community, and everything's out. So as was mentioned, Dr. Cianca mentioned, you have a long race, and you have to really think about how you're going to communicate. And so, I try to bring in things that are, they're limited resources. So we're trying to be innovative in that. So, one of the things I've done this past year in using with the race was actually I started using, having radio communications, phone communications maybe out. So I actually started using GroupMe as an opportunity within our race operations. I tried it at the triathlon back in November, had really good success, and then these in January for the marathon. And it was just very nice along our stations, we had pods of communication. So I have an assistant, and they are monitoring the chatter and working on assets and any information that's going on throughout. So without having a radio, it's instantaneous. We could pipe into who we needed to, and it would allow us, and even our our co-medical directors, they were there. I wasn't there with them, but I'd have to get on the radio. They could see what was going on as well. So it definitely streamlined. I try to look at that and bring in, do an assessment for these events and what what is needed. But my focus is bringing on, this is what has to be done as a minimum, and it's not being overrun. It's just what is the best, what you need to have an effective race from a risk management standpoint, from a communication with local and or state, and even at times federal law enforcement based on the type of event, and bringing those same practices that are at a large scale race like the Houston Marathon, bringing them to a smaller race that may have 250 participants. So it's no different in the type of care, just the type of assets in the situation where you are and how you approach that care.
And so here in just a couple minutes, I've got to sign off, and Jeremy, I'll send it back over to you. So I want to pose a question to both Ray and John. The first time that I really got involved in marathon medicine, John, was when my neighbor, actually, Tom Munoz with the Houston Fire Department, he brought me down, and I got to see all the operations, and I was immediately hooked. And believe it or not, I had never really worked a true marathon or an Ironman. And so the next day, I sent you an email and wanted to get myself and our program more involved. For those healthcare professionals that want to get involved in race medicine, whether it be the marathon, Ironmans, whatever it is, John, what is your recommendation of how they get involved?
Well, first of all, I'd encourage them to get involved, because I can't remember a situation where I had too many volunteers. I think the simplest way, if you want to get involved, is to pick an event that you have the time to participate in, both for your schedule as well as for the time involved of the race. Get in touch with the people that put the race on. That might be through their webpage or whatever contact number you might have, and just tell them who you are and what you can do, and they'll probably put you in touch with the right person. So that happens a lot in Houston, where somebody might call the main marathon office and they'll give them my email or my phone number, and I'll speak with them and find out what it is they want to do, what they have for skill and talent, and then try to match them up to the right place. And since most of you out there are probably athletic trainers, it could be a lot of different places, because you have very diverse training and you're very skilled in a lot of areas that lend themselves to this kind of coverage. Identify where your interests are, and then try to find an event that fits those interests, and just put yourself out there. I think most people in my position would be happy to talk to you about helping out.
Right.
Ditto. Same thing here. Here we're trying to get having enough volunteers, and we can always use, and we're gradually getting more volunteers each year. So, definitely, we welcome any medical volunteer. We have more than enough room to put you somewhere and have a good use throughout the course. And it's on the course, that's and even post course, down the finish line, et cetera. So, and we have, for our case, we have 2 days of events. So we have on the Saturday, we have a 5K, a quarter marathon, and a 1 mile kids marathon run. And then on Sunday, we have the half and the full. So, as Dr. Cianca said, just have to reach out to us and or the race organizers, and they'll get in touch with us to get you on board.
And so, Ray, if somebody out there wants to get in touch with you along those lines, they can look you up on Action Medicine Consultants.
Yeah, I guess for the marathon, I would say they go to the Louisiana Marathon, and the email that goes to me is medical@thelouisianamarathon.com. That's for the Louisiana Marathon. And then I know another race that the marathon group is putting on, just came on board, is the Mississippi Gulf Coast Marathon. That'll be in December this upcoming year. So looking forward to initially planning us getting on board and working that one. That's a different one to get on board with and starting that. But then as far as my different events I cover, they can simply go to actionmedicineconsultants.com and they can contact me through that.
And then you both mentioned before the International Institute for Race Medicine, or IRM, and that website is www.racemedicine.org. They have a lot of really great information of coordination and best practices and articles, and along with the information that you get on the NATA website. It really prepares you for getting involved. This is where I sign off. I'll kick it back to Jeremy so you guys can continue on with the conversation. To both of you, John and Ray, it was a real honor to be able to talk with both of you.
Thanks, Josh.
Likewise. Good to see you.
I can tell you. Yeah, good to see you too, man. And I got to tell you, this is now, John, if you'll have me back, this will be my 3rd marathon. And boy, I got the bug. I really got the bug. And this is a lot of fun, and you learn a lot, and you stretch yourself. This last year I did bike EMS, and I loved it. It was my first time doing it, and so I'm really excited about how we can keep growing together. And John, how you decided to use our MAT program and providing services, we really appreciate it.
Well,
So,
we're
Jeremy-
happy to have you, and I hope we have you for many years to come.
Oh yeah, well, I hope so too. Jerry, this is where I turn it over, and my friend, you've done a great job for National Athletic Training Month, and so I'm going to sign off for the University of Houston Master of Athletic Training Program. This is Dr. Josh Yellen. Look us up, www.hhp.uh.edu/MAT. Take care, guys. Thanks.
You too, Josh. Thank you.
Thanks, Jeremy. Bye.
All right, so there are just a few questions I want to specifically ask. We deal with a lot of cross country, and I'll start with you, Dr. Cianca. So we have kids running cross country. They're sprinting for 3 miles, more or less, right? And so then they fall across the finish line. Some of them having a lot of trouble breathing, catching their breath. What is going to be the best way that I can take care of those athletes? Obviously, I need to get them out of the way so they're not getting stepped on. But then what's going to be my next step in taking care of that athlete?
Well, I think if you can, get them up and move them. That's always a better strategy for people. Going down doesn't help you recover so much. So if you can get people on their feet and get them to move, most times a lot of those minor situations are going to go away. If they've got an orthopedic problem, obviously they may not be able to ambulate as well, but that obviously will present itself at that time. But in the physiologic problems that we spoke about earlier, if you see that they're not quite with it, then I would move them to a protected area and start your assessment. And whether it's a short race or a long race, in fact, probably more so with the short races, heat becomes more of a factor, meaning overheating. The weather, of course, is always a factor. Hydrational illness can be a factor in these shorter races too. But by and large, with the short cross-country races, which, anywhere from 2 to maybe 5 miles at the highest level, you're going to see a lot of exertional problems, more so than some of the things you might see in a longer endurance event. So heat comes to mind very quickly. Probably not likely, although it's not impossible for a young person to have a cardiac event. And unfortunately, that happened at the Olympic trials a few cycles ago. So always be aware that that's a possibility. If somebody has some sort of cardiac anomaly under those strenuous conditions, it could play out. But heat is the first thing I think about. Hydration a bit, but mostly when they're under an hour in an event time, I don't worry about it too much unless they've been doing something strange during or preceding the race.
All
right. Dr. Castle, any other thoughts there?
I think the one thing I've seen with cross-country events, especially the first in the year, is when they during the season when they're running, is either they're if they're in school, they don't eat properly. They may have a hypoglycemic, and even at track meets, I think looking at that, but looking at really from an assessment standpoint, looking at neurological status, and I say this, I was at a track meet about 6-7 years ago, a young high school athlete doing several events, moving around, and looked initially to be hypoglycemic, and really looking at that neurologically, how they're communicating with you. And the one thing that vital signs were normal. However, we had the athlete laying down, and when we sat the athlete up, started having excruciating headaches. And to me, that was just this is not right. Immediately called EMS. And come to find out, they had to have a surgery for an aneurysm. So it goes back to neurological. I think it's one of the key things where if you look at neurological status, that's an extreme, unusual case, but it goes back to how if they're walking, they're presenting. Those are really the things you initially look for. and that will you kind of go from there versus what some of the other general orthopedic injuries you may see.
All right. Keep your mind open for these kinds of things because they can happen.
Yep.
But, by and large, you're going to have the common stuff. And don't forget about asthma too. Asthma is common, especially in, young adults and teenagers at these events because they're kind of revved up anyway. And then there's some exertion. And if it's a cold day or the air quality is not good, then asthma, of course, can kick in pretty easily.
All right. And then for after a race, I know I've talked before about chocolate milk. Do you guys have any sort of thing, like they start cramping up? Is it just kind of give them water, just get them moving, like you said earlier?
Moving helps. Cramps are often the most dramatic presentation you're going to see. I mean, people are uncomfortable, obviously, but there's a lot of histrionics involved in it too. But yes, moving, hydration's important, but it's probably not the only thing. Especially in shorter races, it's really probably more about neuromuscular fatigue at that point, and a gentle but continuous massage or stretch can be helpful. So having you guys available to do that kind of work is important. Ice therapy can sometimes be helpful, especially to a very irritable muscle. It kind of slows it down and calms it down, especially if it's a very isolated sort of cramp. If they're more generalized, and I think about hydration, I think about, the fatigue and trying to keep them moving, but not under a lot of strain.
All right. Dr. Kessel, anything different?
Same thing. I mean, you treat them individually. Obviously, if the cramping progresses, calf cramping is one thing. You get up into, start getting multi areas of the body, from the calf, then they start cramping in the hamstrings and the quads. To me, that's more of a tall tale sign. This is not resolving. So need to go ahead and probably, either refer them to, have EMS transport or main thing, trying to get some assisting with further evaluation, fluids, et cetera. It just depends on, and the big thing is it's different if whether, in here at a high school or college, or professional thing, those athletes better if you're working with them individually versus it's that one person, the visiting team who's having an issue, or you don't see that person. Same as a marathon race. You don't know who that person is and what their daily habits are and otherwise, and don't know the person, the medical history well. So you have to take it just and treat them, just on a case-by-case basis.
All right. You had mentioned, I think you said it was iStat. So here at Pasadena, as far as I know, it's not written that we would do any sort of rectal temperature. I'm not trained to do that. I know that it's best practices to have that available. Can you talk a little bit more about what you said, the iStat and how that works?
Well, the iStat's actually a blood electrolyte monitor. So that takes a small sample of blood, really just not a little bit more than a finger stick, about a cc of blood, and puts it in a little cartridge, and then you put it in the reader, and it gives you back, in our case, electrolytes that you can measure a host of factors in the blood. But as far as temperature is concerned, I would try to get trained in being competent in a rectal temp, because it's definitely something that could come up, and it's not difficult. Obviously you need to be in a protected area for the person's privacy and such, but it's not terribly difficult. If you can put a suppository in somebody, you can do a rectal temp. It's just a matter of having the right equipment, having the right setup, and feeling comfortable with it yourself. Now, in absence of that, should you not take a temperature? Well, no, you should, but keep in mind that a oral temperature or anything that's done externally on the skin is just not going to be as accurate as you'd like. And I would always estimate that those are going to be underselling the problem than overselling it.
Dr. Kessel? Right on.
No need to say he and my exact sentiments. So
okay, so on that same note, where would be the best place for me or for my coworkers here to get trained and do that?
Well, I would start with the school nurse, probably. But then if that doesn't work, I would go to, if there's a team physician, particularly if they're a primary care physician, absolutely, I would seek their help and their guidance. That is a very trainable skill. It shouldn't be anxiety provoking or it's not difficult. It's just a matter of knowing how to do it in terms of, getting that person understanding why we're doing it, putting them in a situation where they're going to be not so exposed and not so feeling so vulnerable, and then doing it with some care. So it's a little bit of technique, obviously, but if you have the understanding of what you need to do, it's a very easy skill to do.
I mean, you can get, I know Dr. Yellen would have that. It's a core requirement in, I know in athletic training curriculums, the vital signs using core rectal temperature. And we actually have as a model, we refer to it as literally the butt in the box. So we have a mannequin and we have our core rectal thermistor, and we go through that, and it literally takes about probably less than 5 to 10 minutes. We can adequately train someone to do that, even our students as well. And it's extremely easy to accomplish. And I know that he would have those assets as well, in addition to your physicians, nurses, as Dr. Cianca mentioned, or even the medical colleges in the local area.
It's probably a point that isn't brought up enough. And I bet you this is true in many programs. And it really is an important skill, especially if you're involved in sports outside, whether it's football or cross country, track to some extent. Anybody that's under a lot of physical strain for a sustained amount of time is vulnerable to it. So it definitely should be in your bag as something to do. And that may be the case, or maybe much more prevalent than we'd like to admit, that people aren't comfortable with that skill. But that might be something for NATA to take up.
Well, I know they've made statements, and that is the part of the best practices, but a lot of athletic trainers in my situation, I'm not comfortable, with a 16-year-old girl.
Yeah.
I'm having to do that. And it's very testy, but if it's the best medical care I can provide, then I need to be able to do it.
Well, and that's an excellent point, because it's a very vulnerable situation for both parties. And you might look in, let's say you're covering a co-ed cross-country meet or some event that has that possibility arise. You might get a co-treater that's a female, whether it's a nurse would be fine. That's their role in this situation. And you can handle everything else, or even a PA. It's better. I would go that route rather than not doing it. And I think that is a very appropriate question to ask. And you are a little bit at risk, from a variety of ways, right? Parent looks in, what are you doing? Or, the kid doesn't quite understand why you're doing it. And it's definitely something you should be prepared for. And I think the best setting in that situation would be to have somebody else alongside of you that is the same gender as the person you're hoping to get the temperature on.
Yeah, Jeremy, I have the same. I think it is a very difficult. You're dealing with minors, and a number of athletic trainers across the country work at a high school setting. I've done that as well, and I've had that struggle as well. It's what is. I think you have to. Again, it goes back to using going back to assessment skills, and if suspected, if they have a core temp, in an oral temp of elevated, or using a tympanic, temperature reading, et cetera, then you want to have that available to get the most accurate reading, so that that they are stable at a core temp. So you have some basis, and that may be something, something to talk with your, I say the athletic trainer high school is talking with your medical director or your supervising physician, and how to best approach that individual situation at your school or with the patient base you're working with as well.
Another thing you could do, because heat is going to present generally in a fairly consistent way. I mean, if somebody's, obtunded and mentally not quite where they need to be, and they're breathing and they've got a reasonable pulse, well, it's probably not cardiac. So I would treat presumptively for heat. That's a pretty good bet. And you're probably not going to hurt them to make them colder. So, pack them and get ice packs in their axilla and their groin, on their forehead or on their neck. In absence of a temperature, that's probably a reasonable thing to do if you've gone through sort of that checklist. Okay, they're breathing, they got a pulse, they're not with me. They've just been in a lot of exertion and it's warm. Okay, treat them as they're hot. That's probably not a bad guess. And because it's worse if you just left them there untreated with a heat problem. That really can be a bad outcome. So you can always warm them up.
Right. Right. All right. So there's a question from the chat room. Keith wants to know, is there anything that you can do on the day of or the day before to limit the chance of injury? I know we've talked about the you got to prepare months in advance, and you're going to need to do the same thing the few days and few weeks before the race as you would a month before, but like a cold tub or anything like that might help prevent injury.
Well, I would say generally stick to your plan. Now, I wouldn't necessarily do anything unusual that you have not been doing as a routine. A lot of the training regimen is establishing a routine that you know is repeatable and workable. So I wouldn't do anything unusual immediately before a race. And that includes like having a pair of shoes that you've never worn before, or eating something that you're not used to eating. You know, a lot of times, almost every year, we see this kind of thing, which is hard to prevent, but it's dark before a race starts and people are walking and they trip and they sprain their ankle, they step off a curb wrong. You can't really prepare for that. But I would say as a rule that people should stick to their plan. And there really isn't a lot that you have to do ahead of time if you've been well trained.
Yeah, I think the one I know, I like for example, the Louisiana Marathon. This year was the 5th year back in January, and I've been involved with the race every year except the first year. And I go back to something unusual we talk about is one of our physicians that first year. A runner decided to have a colonic cleansing the day before the race. Now that's just not, it's end up being it caused that, end up being hyponatremic. I mean, just made for a very bad situation all around. So that's something, I know it's extreme. You don't want to do that either, but keeping to normal practices. What I think we've talked about that, and Dr. Cianca mentioned, I was mentioning as well, is having a normal routine. And do that over, moving into the race is very important. Is not doing something new. That's where people tend to get in trouble. They want to try a new routine a week or so out. They want to try new food items. They think they're going to get the edge, or whatever it may be. Just, there's a point where you got to use the KISS principle. Keep it simple, stupid. What you're doing is going to work, and then you prepare for the next race, reassess and prepare. And how you want to perform, and look at how you've done and what your training methods, your hydration methods, your nutrition methods, when you eat, how you eat, etc. The food, the clothing you wear, etc. all plays a big part in that.
All right, parting thoughts. It is well past our time that I told you guys we were going to end. So, Dr. Castle, any parting thoughts about preparing for marathons or long distance injuries?
Not really. I think we've covered a good bit here. I think, I think the last thing I would say is if you're a runner and you're having soreness and listen to that soreness, if it's more than a day or so, then do a consult with a medical professional. You don't want to move through that and causing more problems than it may occur, and listen to your body. Your body's gives good information. And always use that as a guiding force in your training and other aspects for overall your own health and wellness.
I would just mention 2 resources, and it's the International Institute for Race Medicine has been mentioned, racemedicine.org. We're all intimately involved in marathons and endurance events. Any of us that are affiliated with the organization would be happy to help, but the site itself is very helpful, and you can go to that and answer a lot of the questions that you might have. And the other group I would key you into is a little bit peripheral, but is very pertinent to today's world, is the NCS4 conference held at Southern Mississippi University, which I'm sure Ray knows. They're basically in line with promoting safety in sports and spectator events throughout the country and the world. And it's gotten to be quite a well-structured organization in a very short time.
All right. Well, I appreciate all your guys' wisdom. So racemedicine.org, NCS4, at Southern Mississippi. Ray, what was the website if someone wanted to get a hold of you?
They can actionmedicineconsultants.com.
Action
Or
Consultant
for the marathon, if they're looking to bring students, we have our different programs, like we bring LSU students, different accredited programs come in. It's the LouisianaMarathon.com.
All right, and then Dr. Cianca, the Houston Marathon
Is HoustonMarathon.com.
HoustonMarathon.com, and then you can find out how to volunteer or find out some of the best practices for dealing with race injuries there.
I guess Jeremy, also they can also find me at where the LSU is lsu.edu/athletic training. So that's also an avenue to get in touch with me as well.
All right, lsu.edu/athletic training.
Yep.
All right, so we can get a hold of you there as well. This is sportsmedicinebroadcast.com/marathon. So this will be sportsmedicinebroadcast.com/marathon. So you can find this episode, the links, answers. I typed in as much as I could that you guys were saying, but I don't type nearly as quick as you talk. So did my best. I am Jeremy Jackson on Twitter. I'm PHS SportsMed on Twitter. So for my Sports Medicine 1 kids, Josh Yellen at the University of Houston. Dr. John Cianca, if you'll wave to the camera and say goodbye.
Thank you all very much.
Dr. Ray Castle, if you'll do the same, say goodbye. That is a wrap.
All right. Very good. Enjoyed it very much.